Hello, everyone. How you doing? I'm going to talk a little bit about the next step. Dr. J gave an excellent lecture on who do we look at. So if you have 100 people in a room, everyone under these numbers go home. Everyone else hang out for a little bit. So this is a part of the next stage, and we see what's what do we do after we say, hey, you're at a little bit of a higher risk. We need to check out what's going on. So as he said, prostate cancer is the most common non-skin cancer in American men. 1 in 7 men in America will be diagnosed with prostate cancer, and the non-smoking male is more likely to get prostate cancer than the next 7 most common cancers combined. And as he was saying, it's because the generations are getting older, and this is, the baby boomer men are reaching that target age, and as we live longer, the 10-year life expectancy rule is an excellent rule, and that's kind of what we all go by. And this is just what he was saying with the incidence of prostate cancer, 161,000 new cases a year. And we'll talk a little bit, he spoke about screening, so it is controversial. There's no set guidelines, but as he said, the 10-year rule is an excellent rule to decide who to screen and who to look at. And you have to talk to your doctor, as he said. If you're in that 10-year range, you do need to go over that with your physician and say, should I be screened for prostate cancer, and speak to that. All right, so symptoms of prostate cancer. Pre-PSA, there weren't really any symptoms. These are very generic: urinary retention, back pain, hematuria. After the PSA area, the symptoms really didn't change much. These are very nonspecific to prostate cancer. But at the same time, these are the presenting symptoms: urinary frequency, decreased stream, urgency, hematuria. These are all things that men come in with all the time. Nothing that we'd say, hey, you have prostate cancer from looking at this test. So that's the importance of screening. That's why we screen things, because there's no symptom that's saying, hey, look over here. We just want to make sure that there's nothing going on behind the scenes. And as he said, the rectal exam and PSA are the tests. These are just a couple of little jokes. My favorite one is the second opinion in the corner over there. You got to hold 2 fingers up. But the importance of the rectal exam is very high up there, and we do need to examine the prostate. Some prostate cancers don't make PSA, about 10% of them, okay? And that's very important to actually do the exam, feel around, make sure there's nothing going on, and then we take it from there. What we're actually feeling is the back side of the prostate, okay? And that's important because all you're feeling is this posterior, is this wall over here. You don't have any concept of what's going on all the rest of the prostate. And that's why the other test that we're going to talk about actually look at the entire prostate. So there's been a gradual but steady decline in prostate cancer mortality of about 30%, and that began with PSA testing. And he spoke about PSA, so I'm going to click through those. And as he said, we look at the patients. We look at the density of the PSA, how much prostate is there that's making PSA. We look at the velocity, how it changes from year to year. If you have a low number and it goes up a little bit, it's more important to look at the rate of change, and that might raise a flag rather than somebody that's been stable for years. All right, so we look at early detection, best prognosis, but the most important thing about early detection is that you have all the options available at that point. You can decide, do you want to watch it? Do you want to treat it? Do you want to do surgery? Do you want to do radiation? Do you want to do nothing? That's the most important thing. If you know early, you can kind of pick what you want to do. And when the time comes, you can live at your current quality of life for as long as you can. And then when you say, you know what, it's time to do something, we can actually do something then. So prostate biopsies, over 1.2 million biopsies are performed yearly in the US. The elevated PSA is the most frequent trigger. 30% of the men referred for biopsy are diagnosed with prostate cancer. That's not very good, okay? So 30% of the 1.2 million, that means 70% are getting biopsies that don't need them, okay? So it's a random sample. We pretty much just divide the prostate up and take a piece from each. That's not the best way to do things. Prostate biopsy risk, the infection risk is about 1 to 8%. It leads to blood in the semen, blood in the urine, rectal bleeding, urinary retention. These are all things that we'd like to avoid, so we try to decrease the risk of those things happening. And this is the old way that we used to do biopsies. We look at the ultrasound right over here, pretty vague picture. It doesn't really demonstrate anything else. We just would randomly sample. If we see a little dark spot, maybe we'll take an extra piece. But as you can see over here, even on the bigger prostates, you can't really see what's going on up here. It just looks black, so we take 12 cores, we only evaluate about 1%, less than 1% of the prostate for cancer, and the chances of finding the cancer are about 30%, 33%, not very good. So shortcomings, false negative rate is very high. We can tell you, so we do a biopsy in the older way. We take out the tissue, we say, okay, there's no cancer in the specimen, but we cannot tell you that there's no cancer in the prostate. And that's a very important distinction. There's incorrect risk stratification. There could be, as he was talking about Gleason scores, there could be an area of Gleason 6. Next to it can be an area of Gleason 7. We only find the 6, and we say, you can watch this, and there's something real sitting right next to it. Very important to know what's actually going on before you counsel someone on what we're doing. And the detection of clinically insignificant disease is important. That's where, we don't want to overfind the lower risk cancers. A lot of repeat biopsies are going on. A lot of people go around and have had 3, 4, 5 biopsies over their lifetime. Not the best way to do things either, because we're looking for something that we wouldn't know is there unless these newer tests are coming out. And disease overtreatment, that's kind of what the biggest problem, when he said that we were using PSA wrong, we were using these tests wrong, people were treating every type of little bit of cancer that was out there. That's not the way we do things anymore. Now we just want to treat and find the significant cancers. So the goal is to detect high-grade, clinically significant disease while avoiding low-risk disease. So if we look over here, this is the regular biopsies that we do. These black lines represent where we would just randomly go when we're doing them. And in the first little picture here, you can see you can actually just miss one. You could be a millimeter over from a significant cancer and not even know it's there, and say, hey, you have a negative biopsy, but we're missing it. There's something that could be out of reach of the needles. If you don't know it's there, you wouldn't know to stick your needle a little bit higher and find something that's over there. We can see that there's areas, as he said before, the peripheral zone, this little darker blue area, that's where most cancers are. But there are cancers that arrive in the other places also, so we wouldn't know to go there and to look at those areas unless we actually knew, hey, there's something over there to look for. And then over here you can see they're just nicking the end of a lesion. They didn't get the meat and potatoes of it right in the middle. That's also very important, okay? So you don't want to undersample, you don't want to find, you don't want to find the edge of a lesion and not be able to say, hey, there's a Gleason 6 on the edge, but in the middle of that core, there's something that's more aggressive. We want to know about that before we counsel people and say, hey, you can watch this or you need to treat it. So this is a 3D model of a biopsy that we do. This little highlighted spot over here is a lesion. These cores on the bottom here are what we normally do. Okay, so you wouldn't even look up here if we didn't know that was over there. And I'm going to go through that in a minute. So like I said, as I said, 70% of men have no real answer on whether they have cancer or not after a negative prostate biopsy. And we'll go a little further. So, and as Dr. Cross was saying, prostate cancer is the only solid organ malignancy that is diagnosed by indirect sampling. Okay, we're not looking at an area and saying, hey, there's something here, and targeting that spot. But now we are, and that's kind of what we're going to talk about today. This is Dr. Art Rostenhad. I used a bunch of his slides, so I told him I had mentioned him here, and it's a wonderful picture of him. So he was at the NIH when they developed the technology we're about to talk about. He was a year older than me in medical school, and as these things were coming out, he was telling me, hey, you need to look out for this. This is the next step in therapy. We're going to be targeting lesions. And as it came out, I think I did the first one in Naples in 2012 of these targeted biopsies, and the technology has only gotten better and better since then. All right, so the prostate MRI is very important. Who you go to for it is extremely important. Okay, these are things that I've been doing this for 5 years and 6 years, and I can't tell you that I can read these MRIs correctly. Okay, it's a very technical test to read, and you want someone that this is all they do. Okay, this is what they do all day long, is read prostates. You don't want to go to a place that does a ton of hips and a ton of knees and other MRIs. You want to go to the prostate people, and it's very important to do that. So if I get an MRI report from a place that I don't trust, I make people go to a place that I know about and the people that I trust and have biopsied and correlated all the findings with. The MRI is sensitive up to finding about 80% of 2 millimeters of cancer. that's Gleason 4 plus 3, which is a significant cancer, or 5 millimeters of cancer for Gleason 3 plus 4, which is Gleason 7 cancer. Okay, so these are very small lesions. The MRIs are very good at detecting them, and when we do biopsies, we're finding that that's actually accurate. So if you look at the difference between these two, right here, this is the old way to look at a prostate, and this is the new way to look at it, okay? And you can see there's a very, very big difference in between the imaging and what's going on. And the radiologist is actually very good at reading and saying, you know what, this is something that we need to check out, and this is something that we don't need to check out. But this is the 1980 version, this is the 2018 version. Bunch of different studies that said, yes, MRI is better. I'm not going to go through them with you guys now, but here's another one, and you can see this is my buddy, Dr. Rostenhad. He's at the head of these studies. This was a few years ago. All right, so what do we do? First thing is you get your MRI prior to the biopsy session, and I actually use these to before I even set people up for biopsies, I want to know what's going on in there. Do we even need to do a biopsy? The MRIs don't detect low-grade cancers. They don't really look for them. They're not on the radar. So if something shows up on these, it doesn't say that there's cancer there, that there's definitely something there, but it means that you have to check. Very important, okay? The radiologist outlines a target. He contours the prostate. We get a live ultrasound, so we're combining these two pictures, okay? This is what we use game day. We're taking this and overlaying it on this, okay, which is a very important step, and that's kind of the game changer. We then use the regular transrectal ultrasound probe and are able to obtain our targets. And it's kind of like, and they talk about like a GPS sensor, but when we move the little ultrasound, the MRI picture moves also, and we can actually see where we're going. The fusion biopsy uses state-of-the-art MRI, and it looks at all the prostate. Remember I was saying when you're using your finger, you're only feeling half of it. The images on the ultrasound are not great either. This looks at the entire prostate, looks at diffusion, depending on how tightly the cells are packed. It tells us, hey, you need to look over here and check it out. And the sensitivity specificity is about 90%. And that's really very important. So when the MRI says, hey, we need to look at this area, then it means, like I said, it's not a guarantee that there's cancer there, but you do need to check and make sure there's nothing going on there. All right, so these are different platforms that we use. This is Urinav, there's Navigo, there's a whole bunch of different ones. So this is a picture of an MRI. You see this little dark area over here? And when we're doing it live, we can actually see a little target like that. This makes it much easier to see, right? So this is kind of what we want to see. And then you look at the MRI picture right below it, and you can see the needle going right through the lesion, okay? And that's kind of what we want, all right? You want to know, if I was doing biopsies, I may or may not have hit this area. If you don't know it's there, you may or may not hit that. You might be 2 millimeters over, like I said. It could be an area that we wouldn't even sample up here, and this is kind of the way to do it. After the biopsy, you get a 3D rendition to make sure that you sampled everything you wanted to sample. This particular patient had 3 targets, 3 areas of concern, and you can see the needles going right through all of them. And this is, once again, the standard cores on the bottom, and there's a huge lesion that's right on top that never would have noticed, okay? And this is a very important, this is probably one of the take-home messages, that if you want to make sure that you're finding what's actually there if you're going through a biopsy with all the risks that are associated with it. In summary, prostate cancer screening, like I said and Dr. J said, 10-year life expectancy is very important. The confirmatory tests that he spoke about are very important. Those tell us, hey, how closely do we need to look at this guy that's coming in for prostate cancer screening? The MRIs do help with the biopsy yield. Once you decide, you know what, we need to take the next step and see what's going on, that's where the MRIs come in. And the biggest push, I would say, is to avoid over-treatment, okay? So when they said get rid of PSA testing, that was like in 2011, that was not the right recommendation, and they're realizing that, and they went back and they changed it. If we look at, we want to know what's there, and then you can decide, hey, I don't want to treat this, or I do want to treat this, or I'm going to outlive this. You need to know what's there to decide that. You can't just tell everyone, you know what, we're not going to do it. Those 10% of patients whose PSAs don't go up, the 10% of patients with aggressive cancer, those are the ones that we're getting thrown out with the water with that one. There you go.
Thank you, Dr. Guttman. That was great.